Okay, this is a case that is recent from today. This patient was sent to us from a nearby hospital, obviously a very sick young person, intubated at the time, as you can see, and there are multifocal, multilobar opacities in the lungs. The next one, I think, was just obtained after adjustment of the endotracheal tube, but again, one can see multifocal and multilobar consolidative opacities. The CT is from the outside institution, I think. And this will give you a feel for the nature, the morphology of the multifocal opacities. All lobes are affected. Ground glass attenuating opacities. In some locations, they are peripheral, but not all of them are. Some are located in the central lung regions. So certainly a young person with an acute lung injury. So they said to me, could this be E-Valley? Because she's COVID negative. And the answer would be yes. But then interestingly, looking at the history that they didn't tell me, a nice note written from the outside institution was when the physician there spoke with mom, because the patient was intubated, mom said that she doesn't think that she vapes, or certainly not frequently, but she does know that she dabs marijuana daily and has done so for several months. So by virtue of that information, the findings are certainly very consistent with dabbing associated acute lung injury. And one can find case reports of that. So given that history, this is a case based on that information of dabbing associated acute lung injury rather than E-Valley. And I know David has shown some cases. I can't remember if they look like this, but certainly the case reports obviously show cases like this.
It makes you wonder, Howard, it's probably the solvent or whatever they say. I think that's butane. So these vaporized solvents rather than the actual compound in the solvent, whether it's
Right.
nicotine or THC or other ones. And that's why we saw some EVALI patients who didn't use marijuana, who just used over-the-counter stuff too.
Yeah. But certainly there's high temperatures associated with it and vaporization of bad stuff.
Yeah. Don't
Yeah.
inhale oil. It's not good.
Yeah. So that was from today. I'll show you another case that came in and also today. So I don't have complete information, but I can tell you that, and this is from the outside, that the patient is intubated with some acute respiratory failure, but the following radiograph, which is this one, was the one that showed substantial change. So there is a before and an after here. And the before and the after on the 14th was CPR. So CPR was administered for apparently quite some time at the outside institution. So I'm going to show you quite dramatic changes that one can see from vigorous CPR. So that's not what I wanted, and I'll make that go away. So here are some of them. We can see here there is a very large hematoma in the anterior chest wall. You'll see that there are buckled and acute rib fractures. And that is a big hematoma. There is a hematoma in the anterior mediastinum. And alongside, I'll show you the fractured sternum. Here, we have a lot of extrapleural associated with displaced fat, the extrapleural fat sign of hematomas adjacent to rib fractures. And here you can see a nice example of the so-called extrapleural fat sign. So pleural fat and then extrapleural hematoma adjacent to fractures. And then I think it's very likely that these focal opacities up here are lung contusions in the upper lungs from the CPR. So pretty dramatic findings of, let's say, vigorous CPR. Maybe the most substantial CPR-associated injuries. Oh, there's also mediastinal air just in that location, which I think is reasonably attributable to the Macklin phenomenon associated with the chest compressions, most likely. So anyone think that none of that what I've mentioned is probably not CPR related? I think they all are. The basal atelectasis in an intubated patient I expect, but all the other findings that I showed.
The only ones I would, and I'm not sure, you may be absolutely right, is those possible contusions. They looked kind of, I mean, usually contusions are more amorphous, and yours are very dense.
Sure, it's true.
Yeah. And they're
So
usually,
that's presumptive. It's
yeah,
presumptive for sure.
I don't know if you can generate enough decelerative force to cause a contusion. I mean, the lowest energy trauma I've seen that caused real contusions was someone getting tackled in football.
Okay,
But I mean, it's very possible. But
possible.
that hematoma is impressive, though.
Yeah, that's a lot of force that went into this
Yeah.
CPR, isn't it?
Do you guys? I've noticed probably just in the past few years, we seem to CT everybody who gets CPR now.
Oh, no, I don't think so. I'm not exactly sure. I think what this was done for exactly. I don't know if it was a PE study or something else.
And it may be they're looking for a cause of the arrest, but they're very interested in any injuries because I mean we find these anterior buccal fractures
Mm,
fairly commonly, and I've seen a few sternal fractures. They're very mild, but they're real, and they're usually looking, I guess, for a cause of it. But I've noticed sometimes the history is just CPR now.
yeah, I haven't seen that per se. I don't think that I know of. That it says CPR, look for injuries kind of case.
Yeah,
Yeah, but pretty dramatic, huh?
yeah, no kidding.
Okay. This one is interesting in terms of the pathology. So here is a lady with multiple pulmonary opacities, nodular metastases, opacities of different sizes consistent with, in this context, metastases, and quite large over here. Here is CT. Again, large, small, different shapes and sizes. Now, interestingly, we see that some are cavitated, as you can see there. And I haven't seen this case in a while, so I can't remember, but I think this may not have been a spontaneous pneumothorax, but may have been after an intervention, maybe a biopsy, the pneumothorax that is. Let me show you what the interior of these look like. The areas of low attenuation within, quite striking, presumably foci of spontaneous tumor-associated necrosis. So of course, the question is, what is the cancer? And I think if we get a history of uterine cancer, we would think, okay, uterine sarcoma should be first, nodules, different sizes, cavitation, that would be fine. With large nodules, particularly if they're not cavitated, we might think of the so-called benign metastasizing leiomyoma as an etiology. But this one on biopsy of the lung and the uterus is a PEComa. So here is the path, and it is a malignant PEComa, perivascular epithelial cancer. And just in terms of context, what about these so-called PEComas? They include, of course, the angiomyolipomas, lymphangioliomyomatosis, I've never personally diagnosed, I don't think, a clear cell sugar tumor of lung, but some number occur in the uterus. So that's in the differential diagnosis of an unusual uterine cancer. So this one is a malignant PEComa of uterus, behaving obviously badly. So that was really interesting pathology.
What was the other one you mentioned? A sugar tumor?
Yeah, I don't know what this thing is exactly. The clear cell sugar tumor of lung. I don't really, I'll have to look up and read up more about that because I don't know anything about the so-called sugar tumor of lung.
Yeah,
I've never diagnosed one or seen one.
cool.
Yeah. So one of the PEComas, huh? But
Wow.
a bad actor.
Yeah.
Yeah. This one I'll show you and see what you think. So this patient, in summary, came to us from the outside because we have surgeons that do the complicated acute aortic syndrome cases. And at the time I saw it, I got the impression that the surgeon here accepted the diagnosis that came along with the patient of penetrating atherosclerotic ulcer with IMH, hematoma, and they proceeded to treat the patient, as you'll see, with a stent. I don't think that they got a second opinion from anyone here, but I think they just acted upon the information that they had and the report that they had. But what's a bit complicated here, as you'll see, is that there is a history of a dissection. So here you can see, starting in the abdomen, that we have a communicating dissection. We've got a true and a false lumen. So that certainly complicates things. Now, one of the pitfalls here is that we don't have a non-contrast to look at. In order to assess whether this here or any component of this is potentially an acute hyperattenuating intramural hematoma, rather than just part of the dissection that the patient has. So first off, when I compare the attenuation of, say, the non-opacified blood in the vein there, and I look at this over here, they're pretty similar. And this by appearance and measurement here is not that of an acute hyperattenuating intramural hematoma. Now, granted, they're probably influenced by this and by this, but in my own mind, I'm not certain that this is a new penetrating atherosclerotic ulcer with intramural hematoma. I think this is very likely related to the history of the type B dissection. And the patient had an episode of chest pain, but apparently it wasn't severe, and he took himself off to hospital. So they stented that anyway, and so be it. But I'm kind of skeptical that this is a separate new pathology, the PAU. I think there may be a ulcer-like projection related to that dissection, but this visually does not look like a hyperattenuating hematoma to me. I don't know what you guys think.
Yeah, I agree with you, Howard. I don't know what other people think.
Yeah. Certainly they're influenced by what information they had and the patient having an episode of chest pain, and they treated the patient with a stent, as you can see there. But I actually don't think that the patient had that separate pathology. And of course, we'll never know whether this here is actually a cause of chest pain or something new or not, because we don't have a comparison otherwise. Okay, those are my cases. So it's hard. Those cases can be hard, and really would like to have a non-contrast CT.
Yeah.
And you would like, ideally, the surgeons to actually talk to the radiologist more often.
Yeah. Great cases. Thank you, Howard.
Okay.
Let's see, David or Peter?
I have two, Jeff.
All right.
So this case, courtesy of Art Stillman. So this is radiograph he read a few days ago. You can see a patient has a clamshell sternotomy here. This is a lung transplant patient. And the abnormal finding is not in the chest, but this pattern of bile gas here is abnormal. And this is a case of pretty impressive pneumatosis intestinalis. And then here is the follow-up abdominal CT. It was done immediately after the X-ray. And here you can see the pretty impressive pneumatosis. So this patient was taken to the OR. They did a laparoscopy immediately, and because they were concerned for bowel ischemia, but the bowel is all viable. So this was established to be benign pneumatosis, and the working diagnosis is that it's related to CellCept, for which the patient's on for immunosuppression for his lung transplant. And there have been several published reports that CellCept can cause pneumatosis, which is benign.
Yeah, we've had a couple recent cases of this too. I think I showed one. I can't remember, but yeah, that's. I didn't know it was related to the CellCept. That's a nice little pearl there.
Yeah. Because I checked their op report and said we think it's CellCept, and then I Googled there's some reports of that. And then I went back, and so it had been going on for about a month, looking back at prior radiographs, and or even longer, but it went the furthest back I could trace it was this chest CT. You can notice some very subtle in the walls here. You can see some little gas pockets developing like there. I don't think this is a diverticulosis here, as I was looking at it in other planes too, but there are some other little pockets. So this is from February 26th.
Yeah, I saw one the other day on it was a follow-up radiograph that has persisted now for a few months, I think.
Yeah. This is pretty much the same. Yeah, persisted for a few months, and you can see it's probably started off slowly and then gradually got a lot more impressive. But I guess the only thing they did is stop the CellCept. There's no surgical intervention other than just went in and checked.
I guess there's really no way to avoid at least a laparoscopy, because with their immune suppression, I think they'd be a little hesitant to watch, because it'd be nice if we could, I mean, if we suggest it, but it's gonna, I don't know, it seems hard to stop further evaluation, because if I remember, our patients usually had benign abdomens.
Yeah. I didn't see if he had what kind of symptoms he had, but okay. And my other case is another cancer. This is a cancer follow-up. The patient has bladder cancer, and I was reading this out with one of our residents, and there's a growing nodule in the lower lobe here, but it's a solitary nodule and it's pretty big, so I found it kind of unlikely to have a solitary mets are somewhat less likely, and to grow that size solitary. So I looked at it. It was pretty low density on the soft tissue, and then I went back a few studies back. I thought this one was the best. This one is the first one I showed was from yesterday. This one is from August of 2020. Here's a soft tissue. You can see pretty low attenuation here. Probably fat. I mean, by measurement, it's negative 20, negative 30. So probably some fat in there. And then if you look at the airways, it's kind of interesting. You can see cylindrical bronchiectasis with some fluid layering there on both sides. So I looked at the patient's medications. He is on Miralax for constipation, so he could be on some other mineral oils for constipation. And then he also is on the asthma treatments of fluticasone nasal spray, which has been reported multiple times to cause exogenous lipoid pneumonia, which is Flonase. I think this is a case of lipoid pneumonia. rather than metastatic disease. And then furthermore, there was a PET CT, which gives more evidence here. There's no FDG uptake at all. So
I think, if I remember correctly, Jeff, did you ever show a case of a legume or something that was really low in attenuation that was aspirated?
Maybe I have a lot of aspirated things, or maybe it was David. Yeah, but I know we showed a peanut one. Yeah, it was a peanut from years ago, and it was really fatty, and it was lodged in an airway.
That's a
hamartoma, bronchial hamartoma. Was that a consideration given
bronchial hamartoma? That makes sense, but then I checked. I don't have it, but I checked like 2 or 3 years back, and it wasn't there. So
the thing is that I mean, they can grow, but I'd be a little surprised for something aspirated being as discrete as this thing is, being just a nodule and not more spread out, the way aspirated things tend to be. What do you guys think about that?
I suppose so.
but then it would just be coincidence that they had all the bronchiectasis in those segments there.
Well, an endobronchial hamartoma could cause the bronchus to dilate or form a mucus plug and things like that.
But don't they grow pretty slowly, David? I mean, usually they're there for many, many years. Peter, you said you went back a couple of years and it wasn't there.
It wasn't there.
Because that's a big nodule. I'd have a hard time. I don't know, David, maybe I'm wrong, but I wouldn't expect a hamartoma to grow that fast.
But do you expect something aspirated to be that discrete?
Yeah, that's a question. Whether
Well, if it's not a foreign body, if it's...
It seems rather large compared to the size of the bronchus that's in, like you would say, how did it get into that small little bronchus? Because the caliber of the airway proximal to it is kind of small, so that maybe speaks a little bit against an aspiration item, I think.
This could be sampled bronchoscopically. But
anyway, either way, it would be a benign thing, right? Because there's no, it would be more of an academic.
I think there could be a component of mucus plug here too, given the elongation.
Okay.
Both proximal and distal, perhaps, interestingly. Yeah.
So I've seen aspirated foreign bodies cause a mucus plug like this. I've seen benign tumors, including endobronchial hamartoma, do it. And I've also seen a small cell lung cancer do it. The small cell lung cancer was too small to be seen, but it formed a little bit of a mucus plug there around it. So I think until you sample this, you don't know what's causing this.
But it's FDG negative, so one could say, well, we just watch that guy.
Yeah, it's been stable for at least a year and a half. And it's FDG negative.
And fatty.
I guess if it was a small carcinoid, that would also have some, I feel like that would have some FDG there.
Yeah, and even just I mean, if it truly wasn't there before, I have a hard time with anything benign behaving that's neoplastic just popping up and then not growing.
Yeah.
Oh, it's interesting. It's kind of neat though.
Yeah.
That's all I have.
All right, thanks.
Thank you.
David, you have anything this week?
I do.
All right.
So here is an abnormal chest radiograph on an elderly man who does have a history of asbestos exposure. He does have some calcification along his left hemidiaphragm that would go with calcified plaque from asbestos. He's got some blending of costophrenic angles, which suggests something other than pleural plaque. Then he's got this big stripe along his lateral hemithorax on the left, and he's had this for a long time. So this goes back, I think the imaging I have on this guy goes back 10 or 15 years, and it's always been there. And decades ago, we had a diagnosis of a cause of his abdominal abnormalities here. So let me show you his abdominal CT. First of all, here's his calcified plaque from asbestos exposure. And then here is all of this tissue around the aorta in the lower chest and upper abdomen. So he's got retroperitoneal fibrosis. This is a extraordinary amount of stuff. You can see that this tissue coats the arteries even down to the iliac bifurcation. And I think he had some ureteral problems. He does seem to have some atrophy of this right kidney and some retained stuff there. So this is retroperitoneal fibrosis. Now, this diagnosis was made decades before people started to consider IgG4 disease. So let me show you his chest CT. Again, we have that periaortic, abdominal, and lower thoracic abnormalities. You know, it's not any less extensive on this later CT. And then here's his rind of abnormal tissue that he had along the left chest wall. So this has been called pleural thickening. It has been called mesothelioma. It has been called lung cancer. The biopsies that were reviewed most authoritatively, most recently, just showed a lot of scar tissue. And you can see that this is definitely a lung condition. It's not pleural because it's got all these air bronchograms in it. So this is a rind of lung fibrosis or lung scarring here, relatively discrete. And given that most so-called, you know, formerly known as idiopathic retroperitoneal fibrosis conditions are really caused by IgG4 disease, this is probably a bizarre manifestation of IgG4 disease here with this peripheral lung scarring. Now, last week, somebody showed a case of adenocarcinoma in this distribution. So, you know, that was on the differential diagnosis, but we have stability over decades. So that argues against a malignant diagnosis for this peripheral lung abnormality. Then we have some round atelectasis down here in the right base associated with a pleural abnormality, some of which is due to his asbestos exposure. So this is the most extensive case of retroperitoneal fibrosis I have ever seen, with just these enormous pads of tissue down here in the periaortic region and stuff like that, and then the ureteral consequences of retroperitoneal fibrosis. So I've never seen IgG4 disease with this particular manifestation. And we don't have a diagnosis of IgG4 lung disease. The man died a couple of years ago, and at the time of diagnosis, they did not look for IgG4. It was that diagnosis hadn't been invented yet. Okay, so abnormal chest radiograph.
It's interesting, this relatively smooth interface between the abnormal and normal lung there.
It's bizarre, isn't it?
It's respecting some kind of boundary, but it's clearly lung because you have airways passing into it.
Yep.
Absolutely.
Very
Okay.
interesting.
I don't get it.
So the rule about IgG4 disease is it does anything it wants. Okay.
All right.
Did you have another
I
comment, Jeff?
think if it was pure collagen, you wouldn't think that airways would still have air, contain air in the collagen, dense collagen. That's weird. Yeah.
Okay.
Sorry.
And then I'd like to show you this this woman who has a history of atrial fibrillation, heavy cigarette smoking, COPD, and a lot of lung consolidation. So this is her current radiograph, and it shows all of this consolidation in mid and lower lungs and bilateral pleural effusion, calcified aorta. And then you can see that you can faintly see that there's some mitral annulus calcification back here, and then there's a more central calcification here and maybe down here in the abdomen too. So, you know, with her COPD and her lung consolidation and stuff like that, she ended up getting a CT for PE. And here's what that exam looks like. So big pleural effusions, lung consolidation, calcified ascending aorta. And then we have this bizarre stippled calcification in the descending aorta here. And then we go farther down. Here's our mitral annulus calcification, by the way. And there's another round of this stippled calcification, which is not just in the lumen, but seems to be internal all the way through the lumen. But obviously the aorta is not being obstructed by this. It's not that dilated. She does have heart failure, and she's got this funny stuff that seems to be in the lumen, but is non-occlusive. So people were thinking of what sort of tumor could this be? It doesn't look like calcification and thrombus. And then one of our radiologists looked at this and said, well, this is probably, well, first of all, what do you guys think? Have you ever seen internal aortic calcification with this pattern that is not occlusive? I mean, it's not a occlusive tumor. So let me show you what the sagittal looks like, and then I'll ask for your suggestion, because nobody knows what this is. So here's our stuff again in the aorta. It's very disorganized looking, but it seems to be stippled calcification. And then down here, and this very stippled stuff.
Is it systemic embolization of like cement or something, methyl methacrylate?
Not that anybody knows. Now, the other bit of history that I just got this morning was that this woman in 2013 she's got peripheral vascular disease, and she had an iliobifemoral bypass or something like that. So there was some abdominal procedure. Now, we don't go all the way down here into the abdomen past these mesenteric vessels and stuff like that. But one of the suggestions yesterday was, could this be a crumpled up and displaced stent? So that some of the laciness could be, the metallic components, and maybe there's secondary calcification on top of those, or something like that, because that would, if this were actually a matrix of little wires and stuff like that, that could account for its being non-occlusive despite occupying the lumen. So that was one suggestion yesterday, and that makes sense. I mean, it looks as if it's got a discrete lower edge, irregular upper edge, and maybe it fractured, and this is a different component that originally was part of a bigger stent that sat here. But why would it have gone retrograde like this in the aorta if it was really for iliobifemoral disease and stuff like that? And
you should put the metal in there too. I mean, even if it fell apart, that just doesn't.
It doesn't look regular enough, does it?
Right.
You don't see a nice basket weave, right? So, any ideas? I was hoping that Seth and Mr. Aorta would be on today to help with this case.
No.
Okay, so she's got atrial fibrillation. Could this, another consideration is that sometimes people embolize chunks of their mitral annulus calcification. This stuff can embolize. I would expect to see bigger chunks and not small pieces not small flecks like what we're seeing down here.
And David, it's also unusual because it's not like it's stuck to the wall. I mean, when you showed it in cross section, it was filling the whole lumen, and it's not distorting it.
Right.
And something's holding it in place.
Yeah. Okay. Is there any way this could be tumor? It seems to me tumor would be occlusive.
Yeah, unless you have like a metastatic bone or cartilage forming sarcoma, or an aortic sarcoma that differentiated. But usually, I mean, we've seen a couple of aortic sarcomas on here that looked really ugly, and there was a lot of irregular soft tissue. And I would think the vessel would expand a little bit too. But I was wondering if this was a weird sarcoma, just given with some kind of matrix. When you first showed it, you mentioned tumor.
Yeah. Well, that was our best guess looking at it before. Okay, well, if anything comes to mind, please
You're gonna leave us hanging.
We're open to suggestions. This isn't her current main problem, and so this is going to probably the workup of this is going to be deferred. I would hope that we could get some abdominal imaging. Maybe there's something going on down there with her previous surgery that would be instructive somehow.
Is there anything vaguely like that in that proximal left subclavian artery, or is it just atheroma up there?
This, yeah, so I think we're the stuff we're seeing here all seems to be in the wall. You know, here we're skimming the wall. It doesn't seem to be in the lumen the way this stuff is. So yeah, I was looking at other vessels and trying to look for the same pattern. It looked for a while as if it also went on to this mesenteric vessel here, but that vessel is small enough that once again, I think we're probably just seeing the wall and not something in the lumen itself. Okay, you know, I was wondering, could this be some calcification process related to renal failure or you know, being on Coumadin or something like that. So I can't, none of that makes sense either. So
No, I mean, it's clearly filling the lumen, so there's got to be tissue or foreign material there, and there's no collateralization, so it's not something that's probably been gradual.
Yeah.
Yeah.
And it's the
The only
intima
thing I
looks
would do
very
is
normal.
I don't know what it is. I would just try to read the op note if I had it to see if, and this is a real stretch, when they did the surgery, they did something, let's say, unusual. I don't even know what they would be though.
Okay. Okay. Thanks, guys.
Yeah,
Appreciate it.
crazy. Bummer. I was hoping you knew what it was.
Yeah. So well, it's probably going to be IgG4 disease.
Yeah, probably. All right.
Thanks.
Thanks, David. Okay, I've got a few cases I can share. So here I have an aorta case that's a little bit, it's interesting. Let's see, there we go. So this is one I came across when I was looking at a radiograph. So I didn't have much history at the time, but when I was looking at this radiograph, I think it was shortness of breath or something. This is a patient, you see has some effusion or thickening there. But what caught my attention was this funny appearance in the mediastinum here. We see displacement of the airway, and the aortic arch or aorta itself looks a little unusual. And you can see there's some intimal calcification here, and there's some soft tissue lateral to it. So I wondered if he had an aortic aneurysm or something like that. And luckily I had a CT scan that we had done here. And so this is his scan that predates the radiograph. And you can see there's this really odd aneurysm just after the takeoff, or right there's the left subclavian. So right at the takeoff of the left subclavian. And then there's this, what looks like a dissection. There's a flap in here. And you can see there's the calcification of the intima, and there's what looks like a thrombosed portion or portion of the aorta with this. And then there's this dissection. There's calcium along it here. And you see there's mass effect on the left pulmonary artery. And then the aorta just turns normal again and goes all the way down. And so I first thought that was really odd for an aneurysm to do that, and also for a dissection just to stop. But as you may have noticed, this guy's, I think he's like 50 or 60. He's got a heavily calcified aortic valve. It's thickened. So I suspect it's bicuspid or functionally bicuspid. And so because I learned from David years ago what is associated with aortic valve, bicuspid valves, it's coarctations, and this would be a good place for a coarct. There's no mention of it, but I dug through an old H&P, and there's mention of a repair of a coarctation at the age of 8 with no follow-up. And he never had sought medical care. So presumably at some point he developed this aneurysm and localized dissection in this. It's probably been there for a long time. He has no symptoms related to it. So a nice, interesting, I've not seen anything like this. I can show you the candy cane 3D here, just shows you this sort of saccular aneurysm with this little right there. You see the little dissection flap in there. So yeah, most coarcts that get repaired now, I mean, they get follow-up in some sort, but this gentleman did not. So I don't know if anyone else has ever seen anything like this, but would you all agree that this looks chronic?
Yes. And by location consistent with surgery related something.
Yeah, and there's just something wrong. I don't fully understand the embryology of coarctation, but there's something wrong with that protoplasm, because think of the juxtacoarct. If they get graft repairs, they can recur next to it, or they can develop aneurysms. If they treat it with angioplasty, it can recur. There's something wrong with that tissue that it just doesn't want to behave itself. And then why they get a bicuspid valve, I don't know, but that's present in about half of them. Okay.
It's like a hypertrophied LV too.
Yeah, yeah, it is definitely hypertrophied, which would go along with that valve. So little thing there. So hopefully he'll get follow-up now, but they're going to leave that alone. This is just a follow-up on a case I showed you, some of you. I can't remember if I showed on the webinar, but this case, I was asked to review this case. It was a young woman who had been in California and then in northern Wisconsin. And this was billed as coxy. And so I sent it to all you on the West Coast and said, I don't think this is coxy. What do you think? It looked more like HP than anything. But what confounded is her, there was her dog, so they were excavating a swimming pool in California, and so risk factor for coxy. The dog had coxy, and she had a positive coxy IgG. And then she was up in northern Wisconsin out in the woods, so blasto always shows up on our radar, as well as all outdoor exposures, including HP. So it turns out they finally did I told them I really just didn't think this was coxy, and after I talked to all of you, I reinforced that. So they did a fuller workup, and there's a bunch of, I think, like fixation tests for coxy, and the final determinant was this was not coxy. But interesting, they did recover Chlamydia pneumonia as one organism, and whether or not that's this or not, but I still think this is probably HP as well. But I just want to let you know that this was not coxy.
Yeah.
And I don't know. Chlamydia pneumonia was I think maybe another red herring, because I mean this had been going on long enough, and that's usually a self-limited community-acquired infection that a standard whatever they use, azithromycin, should take care of. But
so did she spend any time in hot tubs when she was in California?
Exposure under the sun. That's the problem. But it just shows you how anchoring bias can be really, really dangerous because of one lab test or one anecdote. And I mean, it's reasonable to think of coxy because she was exposed to it, but coxy is so endemic that it's probably she probably was exposed to the organism, but she wasn't infected. And miliary coxy, she would be really sick, and you don't just get this pattern of central lobular ground glass nodules. So I suspect this is HP from one of her many exposures, and now that she's back in a different part of the country, she apparently is doing better. So she's away from her exposures, and it's amazing what some corticosteroids can do as well. So yeah, I would bill it as HP and not coxy.
Yep.
It doesn't, coxy are well-defined nodules, not smudgy central lobular GGO things like this.
Exactly.
Mm-hmm. Yeah.
Okay, well, speaking of fungi, so this was a consult I had today, and this is a young guy, he's in his 20s, and he was being he was referred to our institution for a mediastinal mass, and there it is on this CT scan. You can see it's in the subcarinal space, and there's some faint calcifications in it. But the important finding is not the mass, but rather this nodule or cluster of nodules here in the right lower lobe. And you can see they're dense but not calcified, but there's all these tiny little I did not want to do a 3D. There's all these tiny little nodules around it. And if you look along the, let me blow it up here. If you look along the adjacent vessels, there's little nodules there. And so this is a pattern I see a lot, and I see it in this. Look at this vessel here; it's kind of beaded. In acute granulomatous infection, particularly histo, I have seen coxy do it in a patient who had been out in coxy country. But around here, it's usually histo, and they did a whole workup at the outside hospital. They did an MR, which I have all the sequences here. I'm not going to really. The only thing I'll show you that I think supports the diagnosis is there's a post-contrast T1 in here somewhere. Anyway, it just showed some heterogeneous enhancement, but some areas of low signal in the lymph nodes suggesting some degree of necrosis, which I'd not be surprised if this is a granulomatous inflammation. And the PET CT is kind of nice because it illustrates, where's the PET images I want to show here? Here's the MIB. You can see there's a lot of uptake in the lymph node, and there was really no uptake in the lung. And so this is a so-called flip-flop where the lymphadenitis is exuberant and disproportionate to the primary, here's the axial PET images. you can see the uptake in that subcarinal node. There's activity there. It's not super hot, but there's definitely uptake in it. But we don't really see anything down in that right lower lobe. And so we see that a lot with granulomatous infection, particularly histo. And so that actually makes me more confident that this is histo, and hoping to avoid the freight train of pursuing biopsy and all this. But we've talked recently about exuberant lymphadenopathy in histo, and we showed some calcified nodes. I think this is an example of a patient whose nodes haven't quite calcified yet. Here's the non-con CT, and you can see that faint calcification in it. So there's probably already, this is in the subacute phase, but there's still probably a lot of inflammation as this starts to heal. And these lymph nodes may shrink down as the infection is cleared, but we do see calcium in there. So I'm pretty confident that this doesn't really need a biopsy quite at this time. I'm not worried about a neoplasm.
Agreed. That's very interesting.
Yeah. But this is what happens is this freight train of mediastinal mass, and then they start ordering all these imaging studies in the PET. If you don't recognize the distribution and really look at that morphology of the lung nodule, a metabolically active mediastinal mass usually results into some invasive procedure. So hopefully that won't happen. But I mean, at worst, I guess if there's patient preference and clinician preference, they could do just a transbronchial biopsy with a weighing needle or something through the carina and sample tissue without having to do something more invasive than that. But I don't think that's necessary. So this is really cool. I've never seen one of these before. We had this just the other day, incidental finding in a patient, and I honestly don't remember his history. I think he was a cancer follow-up with no metastases. But I noticed this mass here in the paraspinal region of the on the left here, and it had been there, and eventually it had turned out that we actually biopsied it at some point. But before I dug into it, I thought it was kind of interesting because it looks like it definitely has fat in it. I couldn't tell if this was a fluid level with fat and liquid, or if this was just pockets of fat. Here we see it flip-flop, so it's probably actually true pockets of fat. It's very well circumscribed. It's separate from the neural foramen. It's sort of near a joint, but not really. There's no remodeling of the underlying bone, so there's no periostitis or pressure erosion. So whatever it is, it's non-aggressive. It hasn't grown. So I dug back in, and they, at some point somewhere, this was, I think at St. Elsewhere, this was called a pleural mass. So they biopsied it, especially in a patient with cancer. And it turned out it had myeloid elements and lipoid elements. So they signed it out as a myelolipoma. And I thought about it, I'd never seen one anywhere outside of the adrenal gland, but they do occur, but it's very uncommon. And one of my colleagues looked it up quickly and found they reported about a 3% extra adrenal frequency, which I suspect is probably oversampled because we see myelolipomas not uncommonly, and I've never ever in all my years seen one outside of the adrenal gland. And so in the chest is really rare. But it makes sense if you put this lesion in the adrenal gland, you'd be happy calling it benign and probably a myelolipoma. Have any of you ever seen one in the chest?
No, but you know what I would have thought of, and I still think preferentially, is the unusual circumstance of extramedullary hematopoiesis, even if the patient doesn't have a reason for that. On occasion, that can occur as a sporadic, unanticipated finding, a focus of extramedullary hematopoiesis.
Yeah.
When it didn't occur.
Yeah.
I've not seen the one that you a myelolipoma like that. No.
Yeah. So that yeah, and it very well may be. I mean, they only took a core needle biopsy of it, so they didn't have the whole lesion out. So maybe a myelolipoma is a form of extramedullary hematopoiesis since it is myeloid tissue.
It looks as if there's been some modeling of that vertebral body alongside it. It's just slightly concave.
Like right in
so
here.
That just goes with chronicity. It's not destroyed, but just slightly remodeled.
Incidentally, one of my colleagues the other day said, "Oh, do you want to see this interesting case, which was abdominal imaging?" And it was a pre-sacral lesion that looked like this. And he said, "We see this, and these are so-called myelolipomas or focal extramedullary hematopoiesis." So that jogs my memory because apparently the ASCII abdominal imaging folks whether on occasion they see this as an unanticipated finding in a presacral location, and it turns out to be a myeloid or myolipoma lesion.
Yeah, I wonder if a myelolipoma that we think about in the adrenal gland really is a form of EMH, because why would you, and because there is fat in the bone marrow, but why would you have a lipoma with myeloid elements? And it doesn't seem to make sense. Whereas if you had true extramedullary myeloid tissue, you might have some fat in it. So
that's what I favor. That's what I favor. I think I'd be more satisfied with that. Interesting.
Okay. Yeah, and this is my last case here. Let me find the oldest scan. So this was another interesting consult. So this is a guy who is in his early 60s now. So, and he presented, let's see, I thought I had these dates right. Yes. So he had presented with some shortness of breath several years ago, and this is an older CT. And you can see there's clearly a fibrosing lung disease, but we'll look at the distribution. So in the upper zones, it's kind of patchy, it's very subpleural, and it's kind of dense. And then there's quite a bit of anterior, even confluent cystic spaces, so honeycombing or honeycomb-like cysts. Clustering, I think this would meet criteria, but has this really thick thick fibrosis peripherally. And as we go down, it's clearly basal predominant. It stays subpleural. And then all the way at the very bottom, we start seeing what I like to call exuberant honeycombing. They're not the biggest cysts, but there's a lot of them. It's almost just a rapid increase. And you can see we've lost a lot of volume in the lower lobes, and it goes all the way down. So it technically meets criteria for UIP, but it has a couple of funny features. So there's that so-called exuberant honeycombing, or at least in its early phase. I think there's also a nice relative straight line or horizontal line interface that Jonathan Chung and colleagues in Chicago described, where you on the coronal you see this abrupt transition. And then I think we also have sort of a four-corner sign where you have a lot more posterior disease in the lower lobes and a lot more anterior disease in the upper lobes. So it always makes you question connective tissue disease. So this was his most recent scan, and you can see it's progressed, and that honeycombing has become even more exuberant. We're starting to see larger cystic spaces, but it's markedly noticeable in the lower lobes. He's got now traction bronchiectasis, but this is out of proportion. We see bad IPF, but usually you don't see this much honeycombing. Or if you do, there's a lot more upper lobe disease. And what's kind of neat is that horizontal or straight line sort of is preserved even after a couple of years. It's about 2 years later. He's doing worse. He's more short of breath. He was evaluated by a rheumatologist a couple of years ago, and they found nothing very interesting that convinced them this was related to connective tissue disease. However, his recent lab work showed a mildly elevated anti-SSB titer and a 1:80 ANA speckle pattern. So not really high, but not normal. Unfortunately, he's been on nintedanib and is progressing. So I'm not sure what options are for medical treatment, but this is not your run-of-the-mill IPF.
Agreed. Yeah, very unusual for that.
But I thought this was a really nice case because it highlights all those findings that Jonathan so nicely reported. Now, we don't know, it was a small series, but it was a good series. We don't know in larger patients how much this pans out, but I don't know if this is just going to be like an IPAF type patient, or if this is just or he just gets lumped into the IPF patients. But he's progressing on antifibrotics, so that's not good. And not a ton of other things pointing to connective tissue disease, nothing on exam. So just some subtle, or I guess mild lab abnormalities.
I think this is a really good example of this. This almost certainly is autoimmune, and not IPF.
Vasilios just texted me, any upper lobes looking PPFE-ish. I think it's just more conglomerate fibrosis. I think that's a great thought. I was wondering about that. But if I go back to the axials, I'm not so convinced there's the pleural component that we would expect with PPFE. I think it's just dense subpleural fibrosis. Most of this is just extrapleural fat. Yeah. But it's just an interesting observation, I think, that requires a little bit more investigation. But I've been trying to look for these in some of these so-called exuberant honeycomb cases, and whether it's truly UIP or not, or if there's mixed histology, because a lot of times with NSIP we see more diffuse disease in the lower lobes, but who knows?
Jeff, what's the interval between the earlier CT you showed and this
About
later
2
one?
years.
Just 2 years.
Yeah.
So that's fairly rapid progression.
Right, and he presented with advanced disease as it was.
Yeah. I think it's probably going to be RA of some kind.
Yeah, although the anti-CCP is normal, so that kind of big hit against RA. But it may be the one it fall in this IPAF bucket, having some serologic abnormalities. I think they're sending off like the new extended myositis panel that has some other things. Because I showed my residents a case yesterday that was an anti-synthetase syndrome that had a very similar type. It looked UIP-ish, but it had the exuberant honeycombing.
How old is the patient now, Jeff?
He is, I want to say he's about 64, so he would have been in
Wow.
his early 60s.
Yeah.
So it's kind of at the lower end of your typical IPF patient.
Right.
So that's another thing. And I don't think he had a smoking history, which is also kind of another strike against IPF.
Yep.
Can I go back to our previous case for a second? The question of extramedullary hematopoiesis versus.
Yep.
Okay, and that is when I've seen extramedullary hematopoiesis, it's not had the fatty component. And have you guys seen extramedullary hematopoiesis with this much fat?
No.
Yep, I have both with and without sometimes.
Really? Okay.
Yep.
Because mine have been more solid, not showing the fatty stuff.
I'll go back and look at all my cases. I'm sure I've saved all the ones we've shared over the years. And I don't see that many cases of it. We don't have a big thalassemia population, and we have a very small sickle cell population. So, but that would be interesting, and maybe go back in the literature and see if there's anything about it.
But this sometimes occurs, and it's reported in the pathology literature in patients who don't have a reason otherwise to have extramedullary hematopoiesis, like a myelodysplastic syndrome or a thalassemia or sickle cell or any of those usual things. It just sometimes happens for no apparent reason.
That's interesting. All right, guys. Well, it's the top of the hour. Thanks for a great conference, and I'll talk to everyone next week.
Great.
Thanks, everyone.
Everyone. Bye.